We can. Okay, good morning, ladies and gentlemen. If we can ask you to take your seats as quickly as possible, please. There's plenty of space either side and on the front. So if you can take your seats as quickly as possible, we'll be starting in about 2 minutes. Thank you. Good morning. If we can just get everyone to their seats, please. There's plenty of space either side, left or right. There's also space at the middle here at the front. Don't worry, it's not a Tommy Tiernan concert. You won't be picked on if you sit at the front, okay? So you're all very welcome. Good morning and uh, welcome to the Gibson Hotel and welcome to this HSE Patient Flow Academy conference. My name is Barry McLaughlin. I will be your MC today and I'm absolutely delighted to be here. Um, just to talk a little bit about, I suppose, this event, and I can't promise you the political drama of having Michael O'Leary emceeing the event, but we'll try and keep it as relevant to the issue today. Um, the purpose of this academy, this conference, is to bring our healthcare staff together to share and collaborate good practices through patient flow and safety, and also to encourage innovation. And those of you who have attended other events, for example, HSE Spark, it won't come as a surprise here. This is jointly sponsored by the HSE Patient Flow Academy and the HSE Spark Innovation Academy in recognition of the hard work being progress by frontline staff to address the challenge of patient flow. And in a moment, we're going to bring up Mr. Bernard Gloucester. But one of the things just to, I suppose, emphasise and point out that we're in the middle of an election cycle. And if you have not been canvassed, you will be canvassed in the next couple of weeks. And one of the things that politicians will be talking about is how to spend your money better, how to bring about efficiencies, how to do things better. And it never ceases to amaze me, and all the time I've been involved in these events, the ideas that people come up with, the examples they have, the efficiencies they bring in, but also the support they're getting from the HSE, from other stakeholders to make sure that happens. So that's something we're looking forward to hearing more about today. Just a couple of housekeeping issues. The usual exits, if you hear an alarm, you know where to go as well. If you can look at your lanyard for a moment, you'll see a QR code. And I'd like you to scan that QR code this morning. If you can take a moment to do it now or do it a little later on. And that will give you all the details of the event today, but it will also give you an opportunity to get involved in other activities later on as well. So that's just something to be mindful of as well. Um, and you, when you're successfully logged in, please press the thumbs up sign so we know that people have successfully joined. Now, obviously, this is an important event as well, and I suppose we want to make sure that we get as much notice and activity. So you'll notice behind me there we have a hashtag PFA24. So if you take photographs, if you're commenting online on social media, if you can use that hashtag as well, that would be very important. And the final thing I would just say to you is this, that within the event today, there are two things that are really important. We have networking opportunities. So there'll be an opportunity to fill out a networking matrix as part of your scanning today. Get involved in that, meet your colleagues, meet people maybe you only know by their name or by reputation. There'll be plenty of opportunities to do that today. The second thing is here, you'll probably have noticed Robin Deasy here. Robin is a graphic recorder. And what Robin will be doing today is, I think this is really exciting, and I'd encourage you to have a look at it as it goes through today. She'll be graphically demonstrating the issues that come up, the things that people talk about. I am told if there is bad language, there is a red pen. So hopefully we won't have too much of a red pen, but hopefully the people over on this side have an opportunity to come over and chat to Robin and look at what she's doing. And this will be available afterwards as well. If anyone needs to have a look at it, it'll be up online as well. We know that the HSE is facing sustained and record growth in urgent and emergency care activity. And we know that this is along with high levels of demand and waiting lists for scheduled care and community services. And this is never more apparent than in an election cycle. And this is something that is going to be talked about and discussed and debated at great length between now and the 28th. Our first session is going to focus on how do we frame that challenge and deal with that challenge. And I'm delighted to introduce a friend to these organisations, these group, the HSE CEO, Mr. Bernard Gloucester.
Thanks indeed. I don't know who thought down on the north wall of Dublin at 9 o'clock in the morning was a good idea. So a couple of empty seats, I'm sure there's people still travelling, but actually it is good to get started early. It is good to get going. Just can I take a moment just before I start to send good wishes to Dr. Mike O'Connor, who's very central to the Patient Flow concept, the Patient Flow Academy, and indeed to today. And I, in fact, heard from him this morning. And Mike's dad passed away on Monday, so he's missing out on today. And we just send good wishes to him and to his family at this time. Patient Flow. Every time I hear the concept patient flow, our heads are always drawn, of course, to the trolleys, to the biggest pressure in urgent and emergency care. And rightly so, we should be concerned for people in that context because that's not just a demand issue, it's not just a capacity issue, it's not just a flow issue, but it is a safety issue. And it's a safety issue at so many different levels. But then, of course, the corresponding challenge of that discourse is that we tend to forget or not have the same conversations about all of the other patient and service user contexts and pathways that also require and by their very nature have flow. And what does that flow mean? And whether that flow is the flow in and out of access to primary care in a GP surgery or to the allied health professionals that make up a primary care team, or to the secondary specialist services of a children's disability network team or a community mental health team or a chronic disease team in the community. People require to access healthcare. And we probably have some of the best outcomes in Europe and indeed across the OECD in so many different measurements of health. And yet we know that our biggest challenge is access. And so I just want to share a couple of observations with you as you go into today, and they're more prompts for you to take or to leave, to set aside or to engage with as you do. In the 19 months now that I've been in this job, one of the things I've attempted to do is to impress on government, to impress on the department, and to impress on the HSE that we really need to stop the narrative of talking about volumetric waiting lists. We need to stop talking about the 700,000 people that are on waiting lists. And that's not because I want to deny that they're there, but it is actually quite a reductionist conversation. We talk about 700,000 people on waiting lists, and then I go to an Oireachtas committee in 9 months' time, and usually a member of the opposition, possibly a member of the government parties, will say to me, and Mr. Gloucester, isn't it terrible? There's still 700,000 people on the waiting list. Of course, everybody forgets they're not the same 700,000 people. And so I want you today to think about the currency of time rather than volume, because it's time waiting. is what actually determines the success or not of patient flow. It's time waiting that usually will impact the quality of service. It's usually will impact the quality of the outcome for the person in their health, and it usually will impact their actual overall experience. And their overall experience is what they relay in the neighbour's kitchen at home when they go home and have a cup of coffee, or when they're out with friends, or when they're in the office having a chat before they start the day. And it's those experiences that get relayed that shape and inform public confidence. And so the circle comes back around. And so how we use people's time is really important, not just our own time, but people's time. How do we use the time of the people that we're serving, the people that we're supporting? How much value do we place on the importance of their time and the importance of time to them? And if you keep that concept pretty much in the center of your thought process, you will be drawn into talking about processes around patient flow. And you'll be drawn into talking about all of the steps along the way. And then we start to think about, can we do something different with those steps that help people? Yes, of course, we need more capacity. I was having a conversation yesterday with some people about the fact that 2031 is here. And what do I mean by that? Well, in 2018, there was a capacity review, one of many done in respect of the Irish Health Service. And it had a pretty good go at predicting that by 2031, you'd need this many primary care professional staff, you'd need this many beds, you'd have this much of a demand from the population. But something has shifted after the pandemic, not least global movement. And so the population of Ireland has fundamentally distorted from what all of the predictions were. And of course, the age profile that we envisaged of people getting older, it is here now. 2031 is here in so many ways. I also want to take a chance this morning to say thank you, to you as professionals in whatever your interest is, whether you're a patient representative, whether you're a nurse in an emergency department, whether you're a doctor, whether you're a hospital manager, whether you're an engineer. No matter what your interest is, I do want to say thank you. I want to say thank you for what you do. And by what you do, I mean over the last year and a half. We've seen demand for care increase in ranges of 10 to 14%, particularly in unscheduled care, running at about 9%. And one of the things that strikes me is that if you take from January to October 2023 and you take from January to October 2024, the growth rate for demand for urgent care alone is around 9.5%. That's 375 people more per day turning up in emergency departments, bringing the daily average roughly to 4,375 people. And out of those 375, a further 75 need beds because we know what the conversion rate is to admission. And yet, despite that additional demand, and largely through focusing on people's time and patient flow, we have reduced the number of trolleys at 8 o'clock in the morning successively over the 10 months of this year, over the 10 months of last year, over the 10 months of the year before. And that's not a place for us to be complacent about because there are still many people waiting. And this morning, Grace, my colleague, will be dealing with and liaising with hospitals and regions around the country around the different challenges that some of them have this morning, this very day. But if we hadn't done what we did in the last year and a half and those improvements, we'd be in a far worse position. And that was largely achieved not through extra resource, but it was largely achieved through what you do, through what people in the system do. And the challenge that I gave when I came to the health service, or when I came back to the health service around access, was for us to move away from the concept of winter planning. Because the summer was as challenging as the winter. Let's face it, we all had learned that that was the case. But we planned and we talked again. And what did we talk about? We talked about the 4 stages that potentially touch through urgent care. We talked about hospital avoidance or before people come to an emergency department. We talked about what happens in the emergency department. What's the process? What's the flow right through from booking in through to triage and so on. And then we talked about the process in the hospital. How quickly decisions get made, the availability of decision makers, the availability of diagnostics, and the availability of decisions for people to be able to move through the hospital system. And we talked about the delayed transfers of care, reduced roughly from about 500 to 350 a day, but still 350 a day is a shocking indictment on our system and the rest of our system, because those 350 beds roughly would about cover most days the trolley pressure. And then we talk about post-discharge and what are the processes post-discharge that help people, particularly to help people avoiding the need to come back to hospital unless the need is acute. And so as you go through today and you talk about process, I really would ask you to think about not the elaborate and over technical statements, but to stop and to pause and to think about the simplicity of steps that make up a process. The process by which you came from the front door into this conference centre today. The process of steps, and then walk in the shoes of the patient or the service user and think about their time before we think about our time. And that's what improves patient flow. There are lots of technical and clinical things that can improve. There are lots of things we can do to create pathways that avoid the need for people to come on a particular process. And yes, we should do all of those. But we can't say to people, listen, would you hold on there till we finish out something in 5 years' time and we'll be back to you. We have to deal with the now as well. The next, the slant care, the shift to the left, we have to keep pursuing that. But the here and now today, the pragmatic reality of the experience of people today, and ultimately patient flow is about people's time. Thank you.
Bernard, again, thank you very much. And I think, if we look at this part of the session, which is framing the challenge, I mean, even those figures, over 300 people more a day presenting to any emergency department, the challenges you're facing, things that are happening. And the next few speakers are going to look at it from I suppose, the clinical point of view, but also the patient point of view as well. I was also struck by one thing that Bernard talked about, putting yourself in the shoes of the patient and the patient's safety. And that's been a theme for many of these conferences, thinking about it from the point of view of the user. There's also another thing he said about safety, and I should point this out for any of our speakers. The steps here are quite narrow and high, and I don't want to be the person to shout, is there a doctor in the house, in the event someone falls? I should also point out at this point, I used to be a medical negligence and personal injury lawyer. So if anyone does fall, my card will be available afterwards if you need anything too. Um, on the theme of the issues and the problems we have, our next speaker, on the theme of a wicked and deadly problem, is the clinical lead for emergency medicine program, Dr. Rosa McNamara. Dr. McNamara.
I can confirm that they are pretty narrow. Listen, what I'm going to talk to is the current state of patient flow in Ireland, the challenges that we are currently facing, and some of the initiatives that we're undertaking to improve outcomes and efficiency. There may be a little bit of reflection of the topics that Bernard has mentioned, but I think that it will all make sense, and perhaps I'll show you some pictures. So I suppose the bottom line in terms of talking about healthcare delivery is that it is complex. There are multiple moving parts, and demand and the factors that affect demand are also complex. So there is not one single solution. As Bernard mentioned, we have this insatiable demand for healthcare, with that particularly obvious with the increasing demand for unscheduled and emergency care. And despite this, our KPIs have improved. So although we see, our 8 a.m. trolley figures dropping and our pet breaches dropping, even with those gains, we still feel those challenges in our clinical environments. And if you focus particularly on that group of patients aged 75 years and older, we see this disproportionate increase in demand for urgent and unscheduled care. And again, that reflection in the change in the admission rate. And our 24-hour pet breaches, despite all of our best efforts, remain stubbornly high. Bed capacity is certainly a concern, and our bed capacity doesn't compare that favorably to the OECD average. And more importantly, perhaps, our occupancy rate does not compare favorably. So running at 90% compared to 70%, the average for the OECD. Several key issues do slow flow. Delays in admission, inefficient admission processes, communication breakdowns, inefficiencies in discharge processes all culminate to affect how a patient's journey is optimized and how they access the care they need. And that impacts both our capacity to deliver good care, but also our capacity to ensure that there's consistency and quality in the care that we can deliver. And all of those problems compound and impact patient outcomes, so that despite the improvements and massive efforts of many of the people in this room, we still have experienced delays in how people can access services. And it is why a comprehensive approach to tackling the problem is needed. And I know that I'm preaching to the converted here. I know that in this room you care about flow, but to reiterate, the crowding that we see in emergency departments is but a symptom of poor flow within the system. And we know that that crowding is associated with poor outcomes for patients, not least an increase in inpatient mortality for those patients who experience delays in their transition of care from the emergency department to inpatient services. And that's not just in one jurisdiction. That has been borne out through the research in several. And beyond the emergency department, we do know that not everything we do in our hospitals adds value to the patient journey. We know that there are direct and indirect complications and consequences of being stranded in a hospital. So improving flow does require a whole systems approach, and all those interdependencies extend from the community through to the emergency department, into inpatient operations and back through discharge processes to the community. So efforts need to be aligned across all of these areas to minimize delays and to provide consistency in care. And it calls for a different way of doing things, frankly. The way we've been doing things for the last, I'm going to say 100 years, is not working anymore for what our patients need. And we talk about breaking down silos, trying to optimize resourcing, and endeavoring to create these seamless transitions. But fundamentally, patient flow is a team sport, and everybody in the team, everybody in our health system, everybody who interacts with our health system contributes to that flow. Again, it's not one solution and there's not one person that can fix it, but many of us together in this room coming together could probably put a dent in the problem and help to improve flow. So our response is the HSE Patient Flow Academy. And our idea is that we would empower healthcare staff and leaders to drive and sustain improvements. We're focusing on leadership development, staff engagement, integrated working, innovation, and transformation. We're hoping that by building skills and creating communities of practice, that we will foster an environment where best practice for patient flow can be shared and applied. We are built on 6 guiding principles, so providing a structured approach for understanding and addressing patient flow challenges, just to ensure that it's not just about improving flow metrics, but also embedding changes in the way that we do our business that are sustainable. So in our initial approach, so it's about a year since the Patient Flow Academy commenced, we've had key focus areas for the year. And we've really focused on trying to both develop resources and to share best practices across the country. We've run a series of webinars, which I know many of you have contributed to. And really that was to try and show how other people have met the challenge, how other people have innovated. Particularly, we've had some really inspiring projects from teams that have given us all a different way to think about the problem and made us focus on what we could do for our own patients on the ground. The Patient Flow Excellence Awards we see as a platform for recognising some of those outstanding projects, and they really underscore the importance of innovation again and how local ideas can have a national impact. And again, they showcase how working across functions, across disciplines, can help to solve complex problems. We have amazing assets in our health service, in our communities. But as Don Berwick says, you don't get excellence from pieces, you get excellence from those connections. And really, the solutions are our people. So before I wrap up, I just want to thank all of the Patient Flow Academy working group members, whose expertise, commitment, their passion has been crucial in getting this far in our mission. And we want to honour the memory of Willie Reddy, whose work has laid a strong foundation for the work that we have built on. Before I close, if anyone wants to access any of the resources of Patient Flow Academy, they're of course available through the website, and all of the webinars, if you have missed any of them, are available there as well. I want to invite Heather from the Matter to just talk through a video that I suppose demonstrates how emergency department crowding is only a symptom of what is happening in the system.
Thanks, Rosa. So thanks, everybody. The video will pop up soon. This graphic was developed by Alan Coleman. He's a designer in our transformation office. We continue to engage the problem of shut. Okay.
Okay.
Thank you.
No.
No problem.
No, take it.
Morning, everybody. So, as part of our ongoing efforts to address the problem of patient flow, one of the things that we have done is try to make more explicit for staff their role, but also the impacts beyond a trolley car metric in terms of patient flow. So, Alan Coleman, a designer in the transformation office, developed this. And initially, we see the way that it should work. Patients come in, they're triaged, they're assessed, and they move through the system. But then what we see is this is real data from February of last year, and the time is up at the top of the screen. And we can see what happens as the whole system begins to back up. So for patients, importantly, their patient experience time, the increased risk where patients are awaiting triage and waiting to be seen. And we've seen some of the impacts of that across the system over the last period of time. But then also importantly, the impact that it has on ED functioning and the staff working in that situation. I think that's a piece that maybe doesn't always get focused on. It becomes almost impossible to run an efficient ED if you have 100 patients within that system. It's hard to find a place to assess. There's no privacy, but also you're pulling inpatient teams down to the floor to see admitted patients. So it's a way of making it a little more tangible for staff outside of the emergency department, the impact of their role, and the fact that there is a really significant mismatch in the timing. Patients are discharging in the afternoon, but patients are presenting from the morning, peaking at midday. And that is exactly when we need the beds. And it's that mismatch, and their role in trying to expedite that could have a really significant impact. So it's just a different way of maybe bringing it to people. Thanks.
Well, first of all, thank you very much to Heather for, I suppose, showing us graphically, I suppose, what a lot of us know already, but it's good to literally take a bird's eye view on that as well. And I'd also, in particular, like to thank Dr. Rosa McNamara. And a couple of things she mentioned, and I think was very interesting, the team, and Bernard talked about this earlier, the idea of people being the solution, people, those connections, those webinars. And it has been our experience in all of these events and in all of the I suppose the breakthroughs that happen, they don't happen on their own. They don't happen one person coming up with it. It happens with collaboration. It happens with support. And that's where we talk about the networking and everything that we're looking at today as well. So thank you very much to our speakers on that. Bernard and indeed Rosa and Heather also talked about the patient. And our next speaker is indeed that patient. And we want to talk about looking at the challenge from the patient's point of view. And we're going to get the first-hand experience of patients and indeed, I suppose, by extension, their own family's experience of the patient flow. I'm delighted to welcome to the stage Miss Catherine Murphy.
Have we got it? Okay. Uh, Good morning, everybody. Thank you very much for the honour and the privilege of your time and your attention this morning to hear the story of my dad, Pat Deneen. And I'm really taking that theme of voice on board and try to give voice to his experience, but also the experience of our family, myself, my mom, Mary, and my siblings, Sheila, Dennis, and Marion, and to share that with you this morning. So thanks to Mike for the invitation, and thank you to you for showing up at 9 o'clock on the North Wall of Dublin. I know it's tough. There are three parts to my story. One is I'm going to introduce you to Pat, your patient. And then I'm going to talk about a specific discharge experience. And a number of people have already referenced the discharge experience this morning. So I'm going to give you our perspective as a patient and as a family. And then about our search for a nursing home later on. So first, let's meet Pat. Great. So Pat was born in a small village in West Cork in 1934. He was the middle child of seven. His father was the local carpenter and coffin maker and wheel maker. Dad went on to be a carpenter, as did his brothers. And in 1962, he went to Puck Fair and met my mother, fell madly in love, and they got married in 1963. He's dad to five of us, a granddad to 14. I've only managed to get 3 of the grandchildren into the slides this morning. Don't tell the other 11. Before the term man's shed had been invented, he had a workshop down the back of the house, and he loved to spend his time there, and he made wardrobes and furniture. And then in later years, because he was still in the workshop into his 80s, he would make cots for dolls for the grandchildren. He would make birdhouses and generally keep out of my mother's way down in his man shed. He loved to travel. He loved the adventure of travel, and he loved meeting people, all kinds of cousins, and he loved America especially. He loved a few drinks, and he loved to sing. He was a passionate man. So to give you a sense of some of his core beliefs, he said, and apologies, he said that Cork was the best place in the world to live. There we go. Spontaneous bursts of applause are really appreciated. Thank you. So he also said my mother had the best legs in all of Ireland, right into his 80s. As children, he said, if you eat your carrots, they will put hair on your chest. No scientific data for this, and luckily not true. And one of his other classics he instilled in us as children, and that he lived every day, was when you're wronged, or when things are wrong, or worse, that you have wronged one of his children, it's time to put in a few. Get out the red pen there. So we'll bear that in mind as we go through. His other love, obviously, was Cork GAA, especially the hurling, and his medics, his doctors, were rated on their ability to either play GAA. If you didn't do that, at least could you talk GAA? Could you at least name your home team? And banter is important. It's not on the medical degree, but it's really important. And as for the nurses, well, he just loved all of you. So mom was a nurse, so yeah. He had a really big medical file. Lots of stays in and out of hospital, lots of discharges, ambulances. Mom had long since retired, but he kept her fairly busy with the medication. And you know what? We found ourselves in June 2020 with mom and dad, like dad at that stage. Mom was 80, dad was 86, and they were doing fine. Bedrooms upstairs, bathrooms upstairs, workshop down the back. Mom is still driving. There's four of us, one in Dublin, the other three in Cork, and we're managing away. Like we've had the public health nurse, we've had the bars put in. It's all okay. It's all okay. They're living the dream and they're happy out. Happy out. And so the second part, what I'm going to talk you through is this kind of timeline. So I'm not sure if you can read that there. So I'm going to talk you through our admission to his dad's admission to hospital in June 2020, in the middle of COVID, his discharge in July 2020, subsequently a dementia diagnosis, a continual decline. I'll talk you through the fair deal form a little, and then another fall and how we end up at that nursing home and then back into hospital again. But they're the two pieces I'm going to focus on. So in June 2020, Dad had a fall. Not a big one, but he wasn't right. And he had to go into hospital. And obviously it was COVID times, we couldn't see him. And so we had some phone calls and it was clear things weren't right. There was a lot of confusion there. And then in July, the government regulations changed and we could go in to see him one at a time. And at that point, we realised actually he's not the man he was. And his strength is really gone. So they're bringing him up and down the corridor, but like it's clear at this point, he's never going to be able to go up the stairs again. And so we swing into action. My brother swings into action. We realize we're going to have to sort the downstairs bedroom. That's going to have to get a toilet in there. And there's a lot of stuff going on at home when we realize all of this is coming to pass. We know he's coming out, and clearly he wants to come out. My mother wants him out. We all want him out, but we're not there. And on a morning, we get a phone call. Come pick him up now. And I hear all the pressure from the ED and so on. But this is our first point, to stop and say something is very, very wrong. We plead with the hospital wards and say we can't do it. But we do live 10 minutes from the hospital, so like it's possible he's going to come home in a taxi. And he would happily come home in a taxi. We just weren't ready. So we rang our GP, she rang the ward, and we got 24 hours. The 24 hours gave us enough time to get the couches out of the sitting room, move the bed down from upstairs, a lot of grandchildren involved, into the sitting room. We borrowed a commode, we borrowed a baby monitor, and we moved Dad in. He was brought in a wheelchair to the car when we picked him up at the hospital. We don't have a wheelchair, we didn't at that stage. And so we just about got him from the car in the front door of the house. At this stage, he was in need of incontinence wear and he was pretty much unable to walk. We contacted the public health nurse who asked us what was our home care package, and we said, we don't know what you're talking about. We had somehow missed a discharge coordinator. None of that had happened, so that was very, very wrong. You know, you can only contact the public health nurse between 9 and 10, and we were now in a clear crisis at this particular point in time. Public health nurse did help us with sorting incontinence wear. There's special pink sheets. There's yellow slips involved. There's a home HSE supplies office, but you have to have the yellow sheet. You can't take a picture of the yellow sheet. We move in 24/7. We start what we call the Book of Dad. And we start to track his meds, temperature, bowel movements. Does he have bread sores? How is he managing? 2 nights later, when he gets out of bed to get to the commode and he falls and he cracks his ribs, but there's no way we're putting him back into the A&E again. We get a team, and I actually don't know how we got this team, but there was this angel of a nurse came called Liz, and she came from something called, I think they were called at the time the Integrated Care Team, but I can't find that online. I don't know what they're called now, but all I'll say is they're fabulous. She was amazing. She came in the chaos, because at this stage there is a Kango hammer in the hall. There's a plaster due to come the next day. Like it is madness, but she has a cam, she sorts it, and she says to me, you need to get a profiler bed. Okay. She says, you need to ring the public health nurse and you'll get a profiler bed. Okay, because that seems like a thing we would absolutely need. So we ring the public health nurse, but it's not our usual public health nurse. It's somebody who's covering for leave. And that lady who's doing her job and following process says, well, that committee meets every 6 weeks. If you get approved, then that will take another few weeks, and it's really only for people who need the bed. So I go back to my angel nurse and she says, leave that with me. So something is very, very wrong. But the good news is we have the bed by the end of the week. Thank you. At this point, it's the summer and I'm off. My sister is down from Dublin. She's got the kids. There's 4 of us. We're all on the same page, and it's really important in families. We're all on the same page and we're trying to get this working. And so we do the 24/7. We track everything in the book. We're navigating the websites, the letters, all of this. We have 2 separate notice boards, one for mom's appointments, one for dad's letters. We have a shared calendar. We write in the calendar. Sometimes they have appointments on the same day. Sometimes one of them has the same appointments on the same day. And we track who's doing what, calls and visits. And we are full-time on board with doing this. There are a number of systems. And I think this is maybe what it should have looked like, because you've got to get the pharmacy, you've got to get the public health nurse, you've got to get the home care assistant manager person who's different from the public health nurse, and you've got to get the supplies office, there's physio, there's OT, there's lots of fabulous people that should be all connected, but actually when you're in it, it looks like this. He came back a bit with OT and physio, but he never came back to where he was. And mom's role in caring for him just increased, and she's exhausted at this point. But also, she absolutely cannot hand over the care of him to anybody else. You'll know yourself, you can't stack the dishwasher right at my age. None of us, never mind look after our father. So in the August, he got a dementia diagnosis and he continued to decline. So let's move on to 2023. He has a fierce inner strength, a Lazarus quality, if you like, and he makes it to his granddaughter's wedding. He makes it to his 89th birthday and declares himself to be in his 90th year. He makes it to his 60th wedding anniversary, and he's hitting all the milestones. And he's still declining. He's a much more fragile man. He's completely reliant on incontinence wear. He is completely wheelchair bound now. Mom is moving him through the house in a wheelchair, and it's not a pretty picture. We have home helps, home care assistants, is that the right term? They're amazing. We need more of them. We need to look at how much we're paying them. And they're all keeping us going. We're in at the weekends and we're covering off so that they can stay at home for as long as possible, because that is where he wants to be, that's where we want him to be, and that's where mom wants him to be. We know we need to do the fair deal form. Like, that's my strength, it's paperwork. Everybody in the family has their thing. Mine is paperwork. So in the previous, like October, November, I know I need to do it. I really don't want to do it. Like, autonomy is important for all of us, for our personal happiness. And as an older person, your autonomy is continually being chipped away by life. And this feels like another big chip away at their autonomy. So I have to ask them about bank accounts. I have to ask them about their income. I have to ask them to get the only asset they own, their house, valued. And it feels wrong. It feels all wrong. So I'm really finding it hard to do it. And so in April 2020, that's Dad's signature on his own fair deal form. And yes, it felt like asking him to put a nail in his own coffin. And that part is wrong. That's wrong. On the May bank holiday Tuesday, he fell in the afternoon getting from the wheelchair into his chair in the kitchen. And grandchildren close by, they came and lifted him and got him into bed. But this is different. The fall isn't bad. He has a mark, but he's okay. He's okay. But he has no strength in his legs anymore. He's not even lifting a spoon to feed himself now. And we're suddenly looking at another new situation. I've handed in the fair deal form, but we don't think we're there yet. And then there comes a point over the next 24 hours where we're realizing, the carers are saying, look, he is lifted by 2 now. We probably need a hoist. They're talking us through how you do the, I can't remember what they're called, the blue sheets anyway, the sliding sheets. The sliding sheets, we're figuring out how to lift Dad and move her, but there's no coming out of the bed and we're spoon feeding him at this point. And we think with the greatest naivety in the world that we are going to ring and get respite care for him for 2 weeks and maybe it'll all be all right and he'll be back home again. And we're wrong. There are 69 nursing homes in the Cork area. It is easier to book a bed in a hotel in the southern part of New Zealand, 20,000 kilometres away, than it is to figure out if there is any room in any of the 69 nursing homes in Cork. We rang them all. Sat down one afternoon, rang them all. Thought we would be reviewing the HICWA reports and whether they had a garden or not. What would Dad like? Anyway, very quickly we realised there is no respite bed available. We're not going to get a respite bed. And we need to bite the bullet and realise he's not going to come back and we need to start looking at nursing home space. My brother takes leave, I get out of work, and we start to think about the nursing home piece. What emerges is that hospitals have priority, discharge coordinators have priority. We didn't have our fair deal in place, we just had the fair deal form handed in. And the fair deal have staff on sick leave, so they haven't actually looked at the form yet and won't for some time. So if we want to get him into a nursing home, then we will need to pay cash up front, non-refundable, in order for him to access the nursing home. Yeah, and if there's any delay, you lose your place. This is what the nursing home told us. Many of them. You really want to get your dad in here, you get him into A&E. Now, that should land fairly squarely with what you've just been saying about A&E. So, given our previous experience, we didn't want him in the hospital. So we ring and we leave messages and we call to people and we see if we can get a nursing home for him. Our GP tells us that we can access transitional funding. I tell her we can't. She says, no, the public health nurse can. I ring the public health nurse. She says, no, we can't. I ring the Fair Deal Support Office. They say you can't. I say, can I speak to somebody else? My GP says I can. They say, okay, I'll put you on to somebody else. And I meet somebody who says, oh, yes, you can. Okay, so, and it's not really the big thing at this stage because we really need the nursing home place. We don't have the nursing home place at this point, but this is, I'm not entirely sure. Oops, this hasn't moved on. I'm not entirely sure that this is true because I can't find anything online and we couldn't anywhere find anything online about how this works. This is what it should look like when you're looking for a nursing home and the integration that you have talked about should be happening. But in fact, this is what it's like. So this is the parable of the 6 blind men and an elephant. Everybody is telling their truth. Everybody is right for what they're describing, and yet everybody is wrong because nobody is seeing the full picture, and something is very, very wrong. The integrated care team are back with us again, and we're hoping we're getting a nursing home. We have a place for the following week. All is looking good. On the Sunday, the nurses come and they say, we're not happy, think he has to go in. Oh God, please no. Because now it means we lose the place in the nursing home. So doctor came, no, he has to go in. So in he goes to A&E in the ambulance, and we think he's going to die. And in true Lazarus quality, he makes another massive recovery and is flying it. He's back up in the ward. He's on the intravenous antibiotics. He's eating like a horse. He knows every nurse, has categorized them in his favorite nurses, Frank. And we think we're good. Nursing home come in, they assess him, we're all moving again. And it's great until it's not, until there's a scan and actually he might be operated on. No, he can't be operated on. And things are now falling apart again. We were eating ice cream on the Monday afternoon. We were going to get a full team meeting or something on the Tuesday, but we were eating ice cream down in the hospital shop on the Monday afternoon. Mom and my aunt were up with Dad, and we got a call to say, come back up. So myself and my brother went back up. We left the sister eating the ice cream. And we're called out into the corridor, and in the middle of that very busy corridor, because there is no other room, they say, actually, it's palliative now. My aunt is standing there. I'm going, why is she standing? Anyway, so in the middle of all of that, they give Mom a chair and say, it's not good. He's going into palliative care. And as this is happening, Dad's bed goes by and he's brought from the ward into palliative care. There is something very, very wrong with that picture. We spend 11 days in palliative care. There's one comfortable chair. You know this. 2 plastic chairs. And in that picture, there is something very, very wrong. If he was here himself, he would walk out with you for the coffee. He'd trace relations. He'd ask if there was any chance of a pint with the lunch. And he could give out to you. You wouldn't want to be at the receiving end of that. But he was a man who loved people and he saw great kindnesses. And if he was here, he would also talk about the great kindnesses. And there were great kindnesses, unseen in HICWA reports, unseen in KPIs or percentages or awards. Sean, his home care assistant, came to wash him every Wednesday. Tough for Dad, who's an independent spirit. And we never saw this, but he told me that Sean sang all the time while he washed him. And he would warm a towel on a radiator and wrap it around Dad's feet to keep him warm. And that it touched his heart. He spoke about what a beautiful spirit Sean had. There was a lady in the ward, again, unseen, who would come around with the tea at night, great with banter. He loved her. She didn't have any cocoa, though, so we had to bring in our own cocoa. That was grand. And she would go and make him cocoa. These were great kindnesses, and he really appreciated this. When he was in palliative care in that room for the 11 days, every nurse who came in spoke to him, even though he was unconscious. And when they touched him and moved him, they said, we're going to move you now, Pat. That tenderness was beautiful. Those same nurses brought us tea and boiled eggs. On a morning, that is the greatest toast, tea and boiled eggs, when you've had a long night in the room. Frank, who Dad called incessantly every time Frank came into the ward, Dad would call him over. Frank, come here. And Frank would come over and hold his hand and listen to him and say, can I do anything for you? No. And off he'd go again. For all the doctors who talked GAA, And if they didn't talk GA, they were happy to share all their GDPR data about who they were related to so he could trace their people. For the ambulance crews who came in multiple situations with us, when there was tears, when we knew it was Dad's last time leaving the house, and they brought dignity to what was a chaotic situation, and they brought calm, and they assured my mother that she had done a great job and she could stop now and he was in safe hands. They were taking him. There were things that are very, very wrong in the system. And there are people like you that are very, very right. You are the right people doing the right job for you and always trying to do the right thing. I chose not to go into the caring profession, but I give my respect and my thanks to you who did. You chose this for yourself, and I hope you continue to do this for my mother and for all the people that are going to come before you. And so, finally, the credit belongs to you, not the critic. You were in the arena, marred by dust and sweat and blood, and striving valiantly. And we thank you.
Um, all I can say is Catherine described a lovely gentleman, and I think we saw he raised a lovely gentle daughter. Thank you very much. One of the things that just struck me looking at the photographs of her parents, did you notice every picture your mum is touching your dad? You know, it's looking after him as well. And I think any of us who've either been in the caring profession or any of us who've gone through the experience that Catherine's gone through, and I think we've been in one of those camps or the other, will recognise what happens. And this is why today is so important. We hear those stories and we see the things and the solutions that might come available. Okay, Catherine, we thank you very much. Now, our next speaker, and again, framing the challenge, our Chief Director of Nursing and Midwifery for the HSE Dublin and North East, Patrina Donnelly.
Thank you, Catherine, for coming and sharing your story. I think stories like that really keep us all grounded. So thank you for sharing that. So thank you for the invitation. I suppose I'm here just to talk around integrated care framework, which has been developed between hospital services and a number of integrated residential care facilities around the hospital group. We've had this established over 2.5 years, and I just wanted to maybe come along today and just to share, I suppose, what it is and how we've kind of gone on the journey over the last couple of years. So we do know that it's recognised that residents in residential care facilities over 75 years of age are 3 times more likely to be admitted to our emergency department. And I suppose for that reason, we brought in kind of more of a proactive approach to how we kind of link in with our residential care facilities. I don't need to tell people in the room, like COVID had a really negative impact in our nursing homes in terms of, I suppose, how residents were, cared for during that time, how they transferred to EDs, and obviously the nursing homes themselves, that support network and that feeling kind of a little bit of isolation out in the greater ether. So we did have a kind of a reactive response during pre-COVID, and the integrated care framework is about being more proactive about the residents and the nursing homes that we have within our particular areas. So it's to provide a structured and proactive integrated model of care that will create sustainable, robust and enhanced clinical interfaces between the acute services and kind of residential care facilities. The integrated care framework is designed to enhance quality of care for residential care residents in their homes and to develop clinical pathways for the requirement to transfer to hospital when it's not always the ED that's kind of the most appropriate for our residents, and especially this vulnerable cohort. So if we look at some of the challenges that residential care facilities, hospitals and residents are currently going through, there's a number of them. Again, I'm not going to this too much detail, but it's really around kind of the increased complexity of the patients that are transferring from hospitals and the use of nursing homes. No longer are residents going in there who are always, the independent. They're going in with much more comorbidities and much more complexities. Around the staffing framework, we know in nursing homes, predominantly it's healthcare assistants. So again, small numbers of regulated professional nurses working with healthcare assistants. So again, we have to look at our models of training and the care that's being delivered. There's a dominant provider. We all know up to 80% are private from our 31,000 nursing home beds that we have across the system. So again, that can be a challenge. And we're having the international markets coming in and being the dominant market holder for kind of nursing homes in Ireland. We're looking at the relationships that we currently have between acute services and the wider health and social care context in terms of how we all link in, what access do nursing homes have, and that geographically spreads out and depends on where you're living, where you're based in the country, and what access you can actually tap into. And sometimes that access is less than you would kind of get access to if you were in your own home having to access kind of those services. So we need to really look at that. Again, in the nursing homes, it is around the perceived medical input. So it's around the GP practice, the out of hours piece. What does that look like on a 24/7 model? So all of these were taken into consideration when we looked at the integrated care framework and how we could try and assist and support those local residential areas, given that they were our patients that we were maybe transferring in. So we wanted to be able to do that continuum of care. There is no denying the role of residential care facilities. They do act as a continuum of care for any person that kind of needs that, either the next piece of their journey, if they're not able to go home, they don't have that independence to kind of live independently anymore. So they're really important. So really important that we do that support network with them to make sure that they're the best that they can be. Again, just some ticket items. So it's expected by the year 2030, 24 of the European population will be over 65 years of age. So that's not a million miles away. Approximately 5% of older people need residential care facility in Ireland. So I'm even thinking of my older self, like where would I like to be, but what is the care I'd like to receive in kind of these residential care facilities and what does it look like? Compared with the community dwelling population, those in residential care facilities are more likely to have multiple comorbidities and increased frailty, and that's basically why maybe most of them are transferred out to care homes. And currently there are approximately 30 transfers to residential care facilities per 100 RCF beds, so annually. So that's a big use of ED kind of use as well. ED admissions can be avoided, and I suppose we've seen this, and I can go through a little bit of data as well, but up to 55% are maybe not the appropriate kind of transfer to an emergency department. There is always alternative pathways, but what is the focus and what do we need to be looking at in terms of what we're seeing with the data and why people are coming to our ED departments? And again, vulnerable cohort, emergency departments, busy, not the best place. And transfers are associated with adverse outcomes on residents, longer lengths of stay, with a 1 to 5% of presentation of frail older persons dying in our emergency departments, which is not acceptable. So the framework was established post-COVID in a bid to provide more of a proactive approach. It's opposed to our reactive approach that I spoke about. It was one hospital, it was the RCSI hospital group previously, where there was 4 hospitals within the cycle, and we've got 16 residential care facilities, predominantly private nursing homes, but we've had 2 HSE homes as well within that, and around 1,700 beds. The framework is not a regulator. It's not HICWA's role to monitor. HICWA still prevails. It does not replace the nursing home governance. What it does, it fully supports and kind of enhances that kind of care that we can help nursing homes to deliver the right care for our patients that we are transferring into their services. It is a voluntary participation, given that it's private. I had to link in with everyone and make sure that there was a double engagement, and obviously that they participated, and there was an agreement that that would be the participation going forward. And what it is, it's more of an outreach piece. So where we have medical, we have nursing, we have allied health professionals, we have professional specialists going into the nursing home at any given time, and obviously trying to support kind of areas or problem solutions as well, and trying to deliver that within the home as opposed to having to transfer residents to emergency departments. It's based on 4 key integrated care dimensions, basically around that clinical leadership piece. So again, that's outreach piece in terms of what we can offer from the hospital right out to nursing homes. I was part of the COVID-19 nursing home report, and a big piece around that was around quality assurance and actually, looking and seeing what are the metrics available for kind of private and public nursing homes. How can we have that quality assurance, and is it published data that we can all be kind of working towards and kind of building upon? And it's based around around training and upskilling. So on a monthly basis, when we have collated data, we'd look at it in terms of there's 26 quality care metrics that we built with the nursing homes. We collaborated with the nursing homes because they wanted to be part of this as well. So we basically built it. We look at the data every month. We meet as a hub. We meet the hospital. We meet the nursing homes. We bring the nursing homes together, which was a forum and a platform that was never there before. They come together and they share. It's a big piece about sharing how people are doing, how you've reached your compliance, what's working well, what's not working well, and what can we do to help you to maybe try and improve that compliance as well. And the staff provision. So again, like we've got a lot of access to staff across acute services. It's about maybe tapping that into it and actually making it extend across boundaries into these private nursing homes to assist patient care. That's just a suite, and I won't go into it, but obviously that's the kind of, there's 26 metrics that we've talked about. So we map this, we trend it, we track it, and then obviously we respond with something around training in terms of, like, we've done a lot around falls, dementia, a big piece around deteriorating resident. Obviously, when you're in a nursing home, when you have that maybe GP service Monday to Friday, what we see is maybe the out of hours piece where there's transfers coming into ED. So it's trying to get in there earlier, and how can we support that early recognition, and especially where they have a workforce predominantly with healthcare assistants. So it's really gauging training and assessments and staff development around not only the staff nurse piece, but also our healthcare assistants, the catering staff, because everybody works as a team, I suppose, in these small nursing homes and large nursing homes. We've also invited the clinical nurse managers or person in charge to our leadership programs, because we do a suite of leadership programs across the acute service. So we've had people come in from nursing homes that we now do integrated quality improvement plans together. So it has opened up the eyes not only from the nursing homes perspective, but from the hospital. We've learned a lot from our staff coming from nursing homes to understand what are we not doing right, how can we improve as an acute service in order to understand the journey of residents and what staff are dealing with on a daily basis. We've introduced the recognising stop and watch in every nursing home within the framework. Again, this is a tool to help healthcare assistants to really understand and recognise early deterioration of residents. If somebody's not eating, they're just a little bit off, their bowels haven't moved in a couple of days, but it's trying to put it back to the homes to respond and to escalate as required. And then we've done around end of life, catheter care management again. So ensuring that staff are skilled and trained, that their policies are up to date, that they have good governance in terms of falls committees, and how can we support and kind of enhance that piece as well. So just a little bit around the data. As I say, 2.5 years we've been doing this. In 2022, when we first established the framework, we've seen 52% increase of residents coming from our acute hospitals to the integrated care frameworks. And actually, when I delved into this a little bit with the nursing homes and the acute side, the feedback was predominantly, oh, this is great, we've got support, there's a framework in place, this is more of a structured process. So there was built up trust, and there was closer collaboration between acute care and residential care facilities. They love the monthly hub meetings where they come together, they learn, they share, and actually we have opportunities now to look at data together, collectively, and support. Then when we look at the RCF presentations over the years, so again, when we first started this in 22 to 23, we've seen an increase of presentations from the homes around 11%. But again, if you take into consideration the 52% that we actually have increased as a transfer out, that's kind of a lower level of kind of realignment back to bouncing back into our ED department. So it did show us that actually we were doing something right here. And then in 2023-24, we've seen a 1% reduction in the presentations that were coming to our emergency departments. It's slow, but we're getting there. We're making real traction to make sure that residents are being cared for, mostly in the residential care facilities with the outreach piece, as opposed to having to transfer to our busy ED departments and the areas that probably aren't right for those type of patients. We've looked at the data for 2.5 years, so these are the top 5 reasons. Hasn't really changed. Actually, we can transfer this across all nursing homes, I would say, and it matches international kind of guidelines as well and what we're seeing across the country. So the one is around respiratory failure. So again, if we look at this data is now giving us an opportunity to say, well, what can we do differently? What are the pathways that we can put in place that actually bypass the emergency department, because it's not always the right place? So we can see that 30% of presentations still coming to our emergency departments are based around respiratory issues. So what can we do a little bit differently? A large number of presentations to ED because of falls. So again, it's about pulling it back. What are the homes doing in terms of that falls prevention, their governance, their clinical kind of data that we're saying around falls. So it's trying to see what we're getting from our data, and how can we respond in terms of support. Some of the admission conversion. So when we first started this as well, there was like a 40 or 55% admission conversion. So when patients or residents were transferred from nursing homes, 55% of them were admitted to hospital, and 45 of the residents were returned back to the nursing homes. Again, telling us a story, probably not the right place for residents to be transferred. If there was alternative pathways, obviously that would absolutely enhance the care of the residents as well. We're now seeing, I suppose, after the 2 years, that it's now a 70% conversion rate. So what that is telling me, that the kind of presentations or the admissions or transfers are a little bit more appropriate. But still, we're missing 30% of residents coming into emergency departments, that we need to think a little bit differently. We need to build care pathways and actually the different models of care outside of our emergency departments. When we first started a couple of years ago, these were some of the quality care metrics. So some of them are around 60, 70%. Kind of now, every nursing home in the framework is exceeding over the higher compliance of 90% consistently. And actually, this is down to the great work from our nursing home colleagues. In fairness, like, they are open to the support. And actually, when you put data down in front of people, it really spurs them on to maybe just do that little bit more and actually put the support practices in place. One of the good stories around pressure ulcers when we started. So grade 3s and 4s is basically never events in my mind where there's full thickness of skin loss. But there's been a reduction of 73% of grade 3s and 4s since we've implemented the framework. We still have work to do on the 1s and 2s, but at least we're kind of stopping the 1s and 2s turn into 3s and 4s. So again, without the data, we wouldn't actually understand what we're needing to put into place for quality improvements. So high level, 2.5 years full data. We have a full establishment of the MDT across each of the hubs. Now, there has been challenges with some of the hubs in terms of keeping recruitment and keeping services going and sustaining it. But we're in it to 2.5 years, and obviously there's been a lot of great work done. There's been improvements in terms of the ability to maintain patients and residents in the residential care facilities. We've reduced our pressure sores, grades 3s and 4s. There's been compliance, high standards around the quality care metrics on a continuous basis, reduction of ED presentations. We've got increase of hospital to residential care discharges in year 1, and that has been maintained for every year that we've had the framework in place. We have really strong relationships with our local nursing homes. We absolutely, in terms we work together, we collaborate well together. This is a great establishment. In times when we have winter planning coming, we work to try and say, what can we do to help? How can we help you kind of in the next stage? How can we kind of get work together and kind of improve the journey for our residents? Ease of transfer for hospitals. So again, it's moving to that referral as opposed to kind of maybe that out of hours emergency department transfer in, and it's understanding the problem. So again, as I said, the data really does provide us with the opportunity to apply, our training, bespoke training for nursing home colleagues and pathway development. There has been lots done, but I think there's opportunity for lots more to be done. And I think as we move into the regions, it's probably very timely to kind of now be looking and saying, well, what are the resources across integrated care for nursing homes? How can we work a little bit more collectively? And how can we continue to improve on the integrated care framework that has been established and is showing good outcomes? So thank you.
I'd like to thank Patrina for that. I think it was very interesting, again, when there is collaboration, communication, people look at the data, review the data, come up with ideas, the kind of changes and challenges that are overcome and the things that you see happen as well. And that's very encouraging. So Patrina, thank you very much. I'd now like to introduce the hospital manager for St. Luke's General Hospital in Carrick-Kilkenny, Niamh Lacey. And Niamh is going to talk about some of the improvements in their urgent and emergency care key performance indicators in recent years. Niamh Lacey.
Good morning, everybody. I suppose firstly, I'd just like to thank the Patient Flow Academy for the invite here today. And I suppose I know, there's a huge amount of work involved in conferences, but obviously the lead up to it. I suppose I kind of questioned, when you have to ask. I suppose it's about lessons learned on my journey, and I was a bit like, God, how do you stand up and talk about yourself, obviously, and the team that's involved? I suppose I'd like to thank Catherine for sharing her experience and, her family's experience. And I think it actually, listening to it was hard to listen to be honest, but it reinforced the reason why we have to do what we're here to do today. And again, I'd like to thank you for that. So, um, I suppose today I don't actually have much slides. I only have two because I thought it was a little bit pretentious about putting up a whole PowerPoint about yourself and per se. Um, so I suppose I also here our team is here today, and I suppose again it's concreted by the success where we have come. We won first and second place in a Spark initiative, and I suppose it just reinforces the importance of teamwork. Sorry if I got the clicker here. Apologies, I was a bit late this morning. So look, this is the slide. This is where we started on our journey. I'm going to let you look at it. I'm not even going to talk through really. You can see our significant reductions. It's 50% there, and that's around at 120 days. But actually, we're at 56% actually improvement in relation to that where we are at the moment. So I'm going to give you a little bit of a career overview for myself, as I says, was just to say where kind of what I picked up along the way. I'm very conscious that there's a huge amount of learned colleagues here in the room who have a huge experience in unscheduled care. I've sat at conferences and you're kind of going, really, but I suppose from those things and from the outreach and being involved in different, I suppose, areas in the HSE, and particularly in the last 5 years during COVID, that there's so much stuff that we can pick up from, listening to other people. And at the time you mightn't, but you have that moment going, that might work here. So I started my career in the early 90s. I left school. My first job was in Harold's Cross as a healthcare assistant in Our Lady's Hospice in Harold's Cross. So I suppose it was a very high benchmark of a level of care. It's nearly 30 years ago where there was therapeutic care, holistic care, there was therapy dogs. So I suppose I was a bit naive and I set off thinking this is what everything looks like in healthcare. But I found I wasn't. So I headed to London. I was there for 4 years, but when I was there, I suppose my head kind of got a little bit turned by the blue lights of the London Ambulance Service as doing a work experience. So I came back. In 2002 and 2003, I qualified as a paramedic and with the National Ambulance Service. So I spent 18 years there, both it's a clinical role. It continued to be a clinical role, but also a manager role from 2013. So I suppose from here in 2020, I started in St. Luke's in Kilkenny. Now, I would have had a good relationship, I suppose, with the ED and patient flow manager from the ambulance service. Well, I think I did. They probably cursed me every day in giving out about moving ambulances. But so I thought I kind of knew that the processes that happen in relation to unscheduled care. From there, I suppose because my background was with the ambulance service, it's a very process-driven role. I often used to speak to interns when when they be witches in, process is really important. Like when you're at a cardiac arrest in somebody's house, you didn't have time to kind of go, what should we do? What do we think? It was, this is what has to be followed. So it has to be clear and everybody needs to know what needs to happen. So when I arrived into the hospital, I suppose I was a little bit, I kind of know what goes on here because it's all about the ED. And I very soon realised, as most people in this room, it's actually not just about the ED and what and how we need to free up the space. So I suppose I was conscious, I was the new person on the block, and what can I do here? How do I support the people who are doing this job every day? I suppose again, I looked at the process from my point. It's like, okay, how do we put this into a process? Because I suppose I won't lie, I was completely lost as to how this worked. Plus, bearing in mind, this was in the middle of COVID, where everything had changed, like wards that the people in the hospital were like, oh, the PG used to be there, now it's our critical care is here. Well, actually, it's over there now. So even for the people who were very experienced in there, it was different. So I kind of went, well, where am I comfortable with? And I suppose I really needed to know, and I suppose when I was looking back and reflecting on this, is I needed to know what I didn't know, and I think sometimes that's really important. I perceived that, look, it's simple, like I'll help with this, but so from that, I suppose I fell into the kind of comfort zone of, right, what can I do in small bites? How do I support as a manager, I've said this all along through my career, and that as a manager, I suppose, and I from being in a clinical role as well, my job and is to support the people who need to do their job. So we need to support the frontline staff to do what they need to do. So I suppose I started looking at a proof of concept, and that was in conjunction with, I suppose I looked at the process around transport, and I, on a daily basis, used to be just, I suppose, I'm going to say shocked or enamored how the patient flow and how the bed managers actually managed to get what they did done in a day, particularly in relation to transport, because it was just, ambulances, patients going, as we all know, appointments. So I said, right, we'll have to put some process around this, because I'm lost. I can't, and I'm quite a simple person. So if it's not 1, 2, 3, I kind of get sidetracked. So that was my first kind of objective, was looking at that. So we brought in what was a proof of concept, and that was, I suppose, incorporating having a transport coordinator. And I suppose that was the infancy of it. And then it just allowed to take that, I suppose, part away from the busy staff that were doing it. I look down as I see Gron here, and I remember on many a day going into the old bed management office, and I know I was constantly asking questions, and I look now and go, I'd say there was days, and I actually think Gron here, there's a few times when I closed the door, I did hear something thump off the door, but maybe I was wrong. So I suppose it's just that piece of not being afraid to kind of push and push and push. And I know sometimes you have to be confident, but until you know what you, as I said, you need to know. So we're very lucky in St. Luke's, and I'm not taking any credit for this, because when I arrived, the culture there was very much an innovative culture, very much a can do. What can we do? As I said, when you know when I arrived, it was very clear there was absolute definite processes, but I suppose COVID just completely, you know, I suppose tore away processes. Even from an infrastructure perspective, we had a whole new build, so that even totally changed dynamic of having single rooms, which was obviously amazing, but it comes with other challenges. So from that perspective, it was like, okay, how do we bring, I suppose for me, I was like, well, how do we bring that kind of together? So there were so many really busy people doing huge amount of work. There obviously, patients were moving and things was happening, but how do we bring it better? So I suppose that was the start in my head, to look at how do we bring ops, I suppose, and nursing together. And because primarily patient flow, was, and I suppose I think it still is, seems to fall on the shoulders of, from the nursing perspective, i.e. the bed manager and that. So that was, I suppose, in my head going, well, what can I do to actually bring that together? So we'll fast forward in relation to, as I said, we already had a huge amount of work. There was initiatives done before, visual hubs, and could actually see every patient on the boards. But so my colleague Denise, who's sitting here in the front from Ireland East, she tapped on the door, and I'd love to say it was a love relationship at the beginning, but it wasn't, because we had many of a robust discussion. And the reason I'm bringing that up is not to kind of highlight, but I suppose it's very difficult sometimes when you have somebody coming in to say, look, why are you doing this? And I suppose for me, again, there was so much I didn't know, so I was willing to take everything in. It was frustrating. It was like, when people pointed out, but I'm sharing this because I'm saying to people, like, be open to criticism, I suppose, and be open to other people looking in at your processes, because when you're in it, and how objective can you be, I suppose, particularly when everything is so chaotic on a daily basis. So Denise and the girls will allude to this. I don't know, many times it used to be said at meetings, like, but with your patient flow team. And I remember sitting there going, if she says patient flow team one more time, there's one person that's the patient flow manager. That's it. But I remember actually walking at the weekend trying to vent the frustration, and I went, actually, that's what it is. We need to make all those individual people, it's that they are the patient flow team. So the discharge planner. So very quickly, and I'm not sure if the presentations are available, Denise, I'm looking at here to be seen. So I won't go at one of the presentations is in relation to our visual hospital. So the concept of it is, I said there was already this visual concept of the patients and where they were identified, but I suppose the visual hospital was a demand number that we required each day for discharge. It also allows every patient to be seen. So there's a hub, which obviously happens the first meeting early in the morning, 7:30. That's between the handover. There is now an ED huddle, But then, from our perspective, as I bring it back to the support piece, at 11 o'clock every morning, we meet in the visual hub, and that discusses, everything that, but it looks at what the demand, it looks at the predicted numbers. Everybody, it's not just, as I said, the ops and nursing, but it's also radiology. And it just gives that overall view exactly what's happening for the day. And I suppose the focus really was that patient flow is everybody's business. It's not just, it's not just, so it's everybody's business. So from there, I suppose we talk about, I've had a little bit of I'd say, look, I wouldn't say that in the last few months, the way things have transpired around the challenge that we have. But I suppose what is important about getting something and everybody to buy in onto it. When I was starting in Luke's, I think about 7 months in, the vaccination obviously was a huge factor. So I was volunteered to go out to set up the vaccination hub in Kilkenny. So, it was kind of meant to be a 3-week process. It ended up 6 months, but it's probably one of the most valued experiences that I've had. And the reason why is, when you say, like, I remember standing there that night afterwards going, this is never going to happen. I'm bringing nurses, doctors, physios, EMTs, paramedics who have never worked together before. It's a totally different work stream. And we have to deliver this vaccine that we're all going. And I look back and I often thought about, and I've spoken to different people, like, why did it work? It worked because we had a very, very clear vision. The vision was we had to deliver this. The country wasn't going to open up, etc., etc. But from the success of starting, I remember the first day we got, I think, 60, 70 vaccines. We thought we were phenomenal. And then fast forward in a month, we were delivering 1,500 vaccines a day. And that's back to the process being really clear. Now, there was ups and downs, there was tears, there was a few shouting, but it was really clear. And it's back from the process. So, look, and I know I probably sound like a bit of a broken record about processes, but people would say to you, and I think even Catherine's presentation this morning pointed out, when people don't know what they need to do next and how do we navigate it, how are we expected to get really positive results? And it's not always different, and it's transition and it changes. But I suppose from my perspective in the role that I'm in now is around making those decisions, enabling the team that we have there to do what they need to do and not to be afraid to challenge and push. As I said, I mentioned a little bit of luck, and I suppose no crisis goes unturned. We, unfortunately for our colleagues, and I'm not sure if they're here today, there was the fire in Wexford. We obviously had to, like most hospitals around, to support, and we opened up an 18-bedded ward, and that subsequently, I suppose, fast forward, remained open to become surge beds. Now, I've often had people say to me, oh, that's the reason why there's such a success, because you got extra beds. Now, absolutely, it gave us the headspace, it gave us that kind of navigation. But it wasn't the only reason. We all know if you keep opening beds, you'll keep filling the patients we see from the demand and the increase. And again, it's back to having that process in place to ensure. I suppose we have taken very much a stance, and I said I'm very lucky to have such a really strong team. The support from our clinical director, I think there Gary is there. Fiona, the director of nursing. I suppose Fiona and myself started the journey together. She was the patient flow manager when I was the ops manager, and then we transitioned into hospital manager and director of nursing together. So we, I suppose, very much had a clear vision of what we wanted. We had no choice really, because when you're the people committed by experience and you've given out of all the things, you kind of really have to then step up and do something different, don't you, 2 years later. But I suppose from that, there is elements that we feel are non-negotiable, and that I'm not saying you say non-negotiable, because patient safety is obviously the major factor here. And, we all get very frustrated. I'm sure everybody here that looks at the trolley car at 7:30 in the morning and goes, oh, crike, what the day is going to be like. But there is other considerations, and that's where I come back to our role to support the clinical staff to need to do this, because it's not just the ED, it's the huge stressors on critical care, the demands across the house from a scheduled care perspective. The CEO mentioned this morning in relation to that, and I suppose as I said, our shared vision, myself and Fiona in particular, was about it's not just about scheduled care, it's also about the unscheduled care. So we made a conscious decision that we were going to have our day services, which we would have used for surge and for capacity, to be a protected, to 10 beds are protected. And it's really positive to see that since we brought that in, we've had an increase in our elective scopes, our bronxery, our CPs. And I mean, whereas, don't get me wrong, we're this morning, thankfully, a bated breath. You open the thing and hope that you're green. Wouldn't be the day to stand up that you're not. But we're not zero every day. We have been amber. The difference is, if this had happened 18 months ago, we would have looked and went, oh, well, amber's probably not too bad, like, because at least we're not 60 over capacity. And I suppose when you say about the culture and the concept of actually what you accept, a few weeks ago, I was going away for the weekend. I wasn't on call. I opened my phone on Saturday morning. I went, oh, shit, we're amber. It's like, why are we? So anyway, I was contacting. It was, we didn't get the discharge we'd hoped. Critical care was extremely busy that weekend. The difference is, other people contact me going, what has happened? We wouldn't have actually blinked an eye at that, because you would have said, amber, not too bad. And the difference is, it's not always about the zero trolley car, obviously we don't want any patients is, but what we find is it's our ability to recover much quicker than what we were. If we had been red, it took us, and this, it can take 3-4 days, a week to recover. So it's for me, I don't think there'll ever be a really straightforward process, because all of the different things that gets initiatives or gets comes our way, crisis is we have to deal with. So I suppose, you might say, what's next and how do you sustain success? And it's a constant battle. But I mean, that's what healthcare is. Healthcare is, it's high risk, it's complex. I suppose what is next is we have put a particular focus around our ED processes and our PET times, which need improvement. Breed, our aid on for patient flow, will be speaking later. And as I said, the presentations are available. So I suppose that's the what next from the patient kind of flow perspective. What's next for say myself and the leadership team within the hospital, I suppose, is it's the ask, I suppose, of the support. The CEO, I mentioned this morning, multiple things that we've all touched on, but he spoke, previously about innovation and looking at the successes. And I suppose every day, every staff member that works in a hospital, I feel there's innovation, because we turn up, there's less staff, there's more patients, something happens, people just get on with it, the doors don't close. And having the initiatives, I suppose, the likes of these conferences and the academies support that, but they also, a recognition, I suppose, for Spark Awards. And, some people might say that, but a huge amount of work goes in to, like, I'm speaking just from our own perspective, that went into the two initiatives and awards that were given by clinical staff who are very, very busy. So majority of this is done in their own time. So I would ask, I suppose, that initiative and that support continues. And I do think with our new structures, we're obviously in a very new arena at the moment, but I would hope the Minister for Health, which I know is not now because that's been dissolved, spoke about productivity. And I suppose I remember the day that there was an answer, everybody kind of went, "Ooh, productivity, that sounds a little bit industrial. How do you link it to healthcare?" I would say we should look at productivity, from a management perspective, because we have to be productive in order to create improvements. And I'm just finishing up now. I suppose from that perspective, I would ask that we all know healthcare is high risk, and we know there has to be a focus in crisis. My background, ambulance service, it is crisis management. That's what I'm comfortable with. But I would ask that the look is at the areas that are doing really well, because when somewhere's doing well, the culture is good. And when it's very difficult to actually pull back if culture diminishes. That's a really hard thing to do. So from that perspective, that's the ask. I would look at the areas, look at the places. There's fantastic initiatives happening, and just focus on that, not the bigger picture. Thanks very much, everybody.
It's a remarkable set of statistics from Neve there, and also the idea of, I think I've often heard the expression, if you have a good relationship, you can survive a good row. My only worry is, as an Offaly man, that she might and her team might start looking how they're going to look at the Kilkenny hurling team, because they've gone backwards. I mean, we'd like to keep them there for a few years if possible. Okay. Now, one of the things I always find fascinating about these events is that we always look to what other countries are doing and what other experts from different areas have done. I think one of the things that's always interesting is how much we have in common and how similar problems are shared. Our next speaker is the National Clinical Director for Urgent Emergency Care in the NHS, and he'll be providing his insights and perspective on patient flow. And this is our keynote speaker, and I'm delighted to welcome Professor Julian Redhead.
Thank you very, very much. It's like walking on a catwalk here. Actually, I feel like I'm on a fashion show, but not really dressed appropriately. Catherine, thank you very much for your talk, because I think it's a real inspirational story. And I wish that that story was not replicated across the world, but I really fear it is. And I know it's replicated within the NHS as well. And I think that's the inspiration that we need to take to start to look at solutions and how we move away from the issues we're discussing. But as been alluded to, this is not just a problem within Ireland and in the UK. This is an international issue. And we've got to look at international partners, and we need to start to think between us, how do we solve the problems together? We've talked about collaborative within a country. We need to talk more about international collaboratives as well to make sure we're getting there. And it's not just about numbers which are coming through. It's also about the complexity of the patients which are coming through as well. We know that the population has changed. We've got an older population with more multi-morbidity situations. And what we need to do is to really think through what is it that we need to do to change around those situations. But it's also that we can do more for our patients as well. And we, as the medical profession, have more ability to make a more accurate diagnosis, to provide better management decisions, often without referring the patient. And I'll come back to that in a second. There's also audits of admissions have demonstrated that patients are being admitted where alternatives may have provided a better care environment for that patient. And that's something which I think Catherine would also allude to from her talk as well. And the trouble with that is that the out-of-hospital services are often fragmented, and they're developed in sort of in piecemeal way rather than a sort of unified way across all of our systems. And then in the UK, certainly, and I suspect it might be true in Ireland as well, that goes for discharge as well. And as we go into discharge, those services are fragmented. We're not able to move patients out of our systems as fast as we would want to. So I want to really start by saying thank you. And your chief executive said this already, but I think it's really important that we recognize the challenging environments that we're all working in across the urgent emergency care pathways. And that's not to say that other parts of the healthcare system are not under pressure. We look at primary care, we look at community care, and we look at mental health. They're all working under huge pressure. But for me, often the symptom of that pressure emerges within the emergency department. And that's what I'm going to sort of focus on here, is more about the emergency department than anywhere else. And it's a bit like filling a bath. We've got a tap which is flowing, and it's flowing increasingly fast. You talked about a sort of 10% increase in your attendances and then the subsequent admissions. In the UK, we talk about a 4 to 5 to 7% increase in our attendances and admissions as well. So that bath is filling. And the plug hole, if you like, can't empty the water fast enough. So effectively, the bath is overflowing. And that bath is overflowing into our crowded emergency departments. That's where we're seeing those issues about the overcrowding. And it also means that because we can't move patients through our system, in the UK, we're also seeing this phenomenon of handover delays from the ambulance, and therefore delays for the ambulance actually being able to get out to the community and to see the patients out of the community. And you could argue that that is probably the greatest risk to healthcare for us at the moment, in that we don't know what's out of the community. Those patients will be having heart attacks, strokes, things that we could care for, but we can't get to those patients in a timely manner. And that often compounds the whole issue By the time they get to the emergency department, they're in a worse position. It takes more to turn around their care and therefore a longer length of stay as well. So in a way, we're in a vicious circle to a lot of what's happening. And what we're also seeing is patients being cared for in what I would call unconventional areas, so corridors, doubling up in rooms and cubicles. And that clearly can lead to harm. And Rosa has already talked about the harm that an overcrowded and long delays in an emergency department can cause. So I won't go into details about those as well. There's also concerns about patients being admitted into a hospital, and especially where we look at the deconditioning that we heard about earlier. And that's because the more that we admit patients, the longer stays occur and the more deconditioning. And again, we're in another vicious circle that we can't move patients back through the system. So we've got to start to cut and break that vicious circle to make sure that we're doing the best for our patients. And I think one of the areas that we also need to talk about, I don't know if it's as bad here as mental health, because we're seeing a massive increase in mental health provision and presentations within the UK. And that really is an issue for us. But I do think this is an issue where we've also seen in the UK that mental health patients with mental health needs, have a shorter life expectancy for physical health compared to a physical health patient. And we also know that the most of physical health predominantly now is emerging as quite a few mental health issues corresponding into those those physical health issues. So we've got to get that right, and we've got to get that balance of mental health and physical health better as we go through this as well. So looking into the future, all right, and I'm going to talk a lot about what the future holds or where I think the future can go in this talk. If we change nothing about how our healthcare is delivered, the cost of that will continue to spiral out of control. Okay, and the amount of GDP, or whichever measure you want, the amount of taxation, the amount of government income output we'll need of this is going to increase exponentially. It's also true that our population is changing. That's been alluded to by a number of speakers. But I think it's really important to re-emphasize this. The shape of our population is moving into a mushroom, okay, where we're going to have a lot more older patients and a lot fewer middle-aged and working patients. Now, that has huge implications for us in terms of how we deliver healthcare and the healthcare that we're going to need to be able to do. And the final part of that jigsaw is that the majority of certainly in the NHS, but healthcare spend is generally in the last 3 years of a patient's life. The problem is we don't know when that 3 years starts. But those are the sort of main issues which we're all coming to think about. So we've got to think about the future. We have to think about innovation, and we have to think about what's changing and what we can do to carry on putting the patient right in the centre of what we do. Now, from the UK point of view, our government has just changed. You're in an election process. We've just come through ours. And our new government has laid 3 challenges out for the NHS. They want more prevention, a left shift, and more digital, effectively. And I think then you could argue against any of those ambitions for any government. But what we need to do is really think about how that's going to work, especially in terms of emergency care, because we will still need that urgent emergency care pathways. We're pivotal. We're right in the middle. And I believe we're right in the middle of all of those 3 changes as well. So I'm going to go through each of those. I'm going to start with the digital agenda, and I'm going to expand that out from not just digital, but also into innovation. And what we've got to really think about is what's going to come in 10 years. Well, let's start with artificial intelligence and machine learning, because that is absolutely coming. An example of this is the ability to break down our population into those who are most likely to deteriorate in the next 30 days. So we can do that for a large majority of our patients. Well, if we do that, what care can we put in to prevent that deterioration? And if we look at aspects of virtual care, and I'll define virtual care because there's often a lot of debate about what all these things mean, but that's where healthcare is delivered by healthcare workers over a virtual telephone, computer-based system, not actually seeing the patient or delivering care to the patient, but very often in a health coaching environment. And we know that if we do that type of virtual care, for those patients, we can reduce the admissions and we can reduce the attendances in urgent emergency care, because that's what the evidence shows us in terms of the literature. We can also use AI algorithms to deteriorate patients who were more at risk of deterioration separate to those 30 days. So take renal failure. And there are really good algorithms now that you can take information from lots of different data systems, identify those patients who are most likely to go into renal failure and treat them before they go into end-stage renal failure. So these abilities are all coming. We can talk about telephone triage because we're doing more telephone triage. We can talk about the fact that we've got voice recognition. And in that voice recognition, we can now identify when a patient's distressed when they phone, as opposed to not distressed by a phone, and use that to understand where that patient is and the response that they're going to be needing. But also to gain clinical information. And I think this is really important, both in the digital front door to the hospital, but also in 111, which is the telephone system that we use, algorithms, where the more clinical information, the more we ask the patient what is wrong in their own words, they can give us that information. And then we get into the stage of actually answering the question the patient wants to know the answer to. Because often we think it's the question that we know the answer to. It's not. The patient has a very different worry and a very different concern to where we are in terms of those. So listening to the patient becomes really important. It can also be used in diagnostics, second read AI in ECGs, and we think about that for acute, but the reality is that new processes are coming out where you can read a lot more future healthcare from an ECG using AI algorithms. So we can then identify patients who are likely to go into deterioration from arrhythmias and other cardiac events into the future, just from that simple use of AI in one ECG. And then the other big area, I believe, is point of care testing. And we can already, in point of care test, pick up head injuries who may or may not need CT scans. And that's through blood tests. So you could put so various things go up very, very quickly following a head injury. We can pick those up now, and we can avoid the need for CT scans. We can pick up the difference between a virus and a bacterial infection. And these are all with little finger prick tests now. Results coming back in 20, 30 minutes, and that timescale will go down as we go through things. And that ability to decide who needs antibiotics and who doesn't will help with antimicrobial resistance, as well as making sure we treat the right patient at the right time in the right place. And then backing all of this will be a revolution in genomics. And that will come as well. And we will see that within the ED department, because it won't just be, do they have a virus or a bacteria? We'll be able to say which virus, which bacteria, and more importantly, for that particular patient, which antibiotic is best used. And that innovation is already starting in ITUs around the country and around the world. So these innovations are going to come, and we need to really think about them. We also, I believe, all have a role to play in prevention. Now, there's primary prevention and there's secondary prevention. And primary prevention, smoking, obesity, etc., that takes brave government decisions. And that means that having things like tax on cigarettes or banning cigarettes or tax on sugar, etc., are important healthcare innovations that we need to be supporting. But we've got a really big role to play in secondary prevention. And that goes not just about using things like blood pressure and AF checks, which have an almost immediate impact on that patient, but also on the population, but also things like health promotion. Now, my old consultant, Robin 2K, always talked to me about teachable moments and proved that in patients who are abusing alcohol, if you catch them in the ED when the effect of the alcohol is there with that patient, they are much more likely to respond to healthcare advice. And I believe those things are so important to all of us across healthcare that when we see a patient with those types of issues, obesity, alcohol, drugs, we need to use that teachable moment whenever we can. And we can also identify those patients with high intensity use and come up with the innovation solutions, which are often the adjuncts to healthcare, not just the type of healthcare that's delivered, but also the wider perspective of healthcare, so housing, heating, and food, etc. And all of this needs to come together in terms of digital integration. And this is going to be really important because all of this data, we need to get permission from patients to use. And I believe patients do want us to use it. They have genuine concerns about data, but we've got innovation again, which can help us. So in the NHS, we're using the NHS app, and we're going to be seeing more of that adaptability of the NHS app. But that will allow patients to carry their own information. And anyone who's used an app recently will know that you can share data for an hour, for a day, all your life to individuals or to a wider perspective of people. And that will give patients control back over their data and allow us to use that data, allow them to pick up the various research projects, because we have to get more patients involved in research so that we understand where healthcare is going and how we can help patients into the future of this. And that then leads me on to the bigger question about left shift and what this really means. I don't believe that it is all about primary care. I think this is about the whole of healthcare needs to shift to the left, not just parts of it. We can build more beds and we can build increased capacity in our hospitals. That's fine, but it's really expensive and we will carry on filling them. But if we truly want to change and revolutionize how medicine is delivered to our patients, well, we need to revolutionize exactly how that care is delivered. So let's go through some of those. The research directs us immediately to continuity of care. And if we get continuity of care right for our patients, we know that reduces morbidity, mortality, but also hospital resource use and care in the community. But that continuity of care is not just in primary care again. There are lots of patient examples who we in secondary care know better than primary care. The transplant patient, the patient with long-term neurological conditions, etc., or cancer patients. And what we need to do is to make sure they also have continuity of care within our system, so that they have telephone advice lines, so that the patient doesn't need to come to the ED immediately. They've got alternatives going straight to outpatient, straight to speciality. And we're building up that evidence base with things like sickle cell anemia as well, where we're trying to change those things in the UK at the moment. The importance of healthcare advice, and how do we make sure that patients who are coming from healthcare providers in care homes that we heard about earlier, but also from the paramedics, and our last speaker was a paramedic, and also from our primary care colleagues, where do they go to get the right advice? And again, this is the single point of access that lots of people are starting to talk about now, and the ability to give that advice to healthcare so that they know the alternatives, because not everyone can know everything, but being able to gain that advice, gain the alternatives to admission to hospital, and gain the information that you need will mean that patients won't need to be transferred into A&E, but can go to alternatives settings. Outpatients. We talk about outpatients, and I don't believe this is just a simple way of shifting your physical outpatient from a hospital to a community setting. I'm not sure that makes any sense, but there are good examples of where patients are, where outpatient settings are changing. In the UK, we have something called Connecting Care for Children, which is a program where the consultants go out to outpatient clinics with GPs, and they go through complex patients with the GPs, seeing them at the same time, learning from each other in that true MDT type style. And I think it's those types of outpatients that we'll start to see in that left shift. But also other things like clinics for symptoms rather than just for specific. So cough clinics. You know, if you've got a cough for 2 weeks, who do you see? How do you then gain those advice? And working those through into community settings, I think will be really important. And then we've talked about the virtual care, but also there's hospital at home. And this is defined by a consultant or a GP leading a healthcare team to provide the care for a patient in the patient's own home that we would normally expect inside a hospital. And if we're really truthful about changing where patient care is delivered, be it in care homes, be it in their own homes residence, we have to think more about hospital at home. And there is really good evidence out there, both internationally, that this does decrease the number of patients who both need admission, but also reducing the length of stay, because patients can be more safely discharged at a much quicker time to reduce that whole deterioration, the whole aspect of deconditioning in our patients as well. The other evidence base that we've got is the separation of urgent care from emergency care. And if we're truthful about a lot of the rising numbers of patients coming in, certainly in the UK system, it's actually urgent care which is increasing as much as emergency care. And there is really good evidence around there about the separation. And it's not just saying, well, we'll take care of the easy patients, but we'll keep the complex patients and they'll still have the long waits. Because the reality is, if we can take some of those patients into a better care environment, it means that emergency care physicians can really concentrate their skills and their training on those most vulnerable patients which needed it. And there's really good evidence of, so the Annals of Emergency Care would show a 10% reduction in hospital admissions. 25% reduction in ED waits from the American Journal of Emergency Care, etc. And really high patient satisfaction has been found as well. The next area to talk about is frailty, because we've already talked about our growing population of frailty. And what comes out in the literature around this is the comprehensive geriatric assessment. Just doing a comprehensive geriatric assessment on a patient reduces their chance of hospitalization, reduces their length of stay, reduces the patient's need to rely on healthcare provision. So it's really important that we look to how we make sure that we can do that comprehensive geriatric assessment, which really starts to understand what that patient really wants from the healthcare system. And it's that is most important as we go through this. So there's various things that we can do. Whenever I talk to patient groups, there are three things which emerge in terms of what we do. The first one is that patients want to know that they're not dying when they arrive in an emergency department. That's absolutely critical. Okay, that's what they want. Once we've reassured them they're not dying, they don't mind waiting for investigations. They don't really like waiting in an emergency department, and we've developed this concept of the same-day emergency care, which is effectively a separate area where we can concentrate investigations, concentrate specialities to avoid the admission of the patient. And they love going into that sort of area. Even though they know they're going home, they know they may have a longer wait, but they're getting to a more accurate and more powerful diagnosis for them, and they're very happy to do that. And the final thing is that patients really, really do not like waiting for a bed once they've been asked to be admitted. So those are the three areas that we need to concentrate on. To me, innovation, research, and evaluation needs to be the centre of everything we do. Our UK government has set us an ambition to return to 95% of patients seen and assessed within 4 hours within the term of that Parliament. So that's 3.5 years, 4 years. We will not do that without using these types of innovation and really thinking very strongly about how we deliver care at a neighbourhood level, not necessarily at a wider level, so we can truly start to think about what the patient wants and care for them in their own home. Part of this learning has to come from the international community. I've been fascinated by the talks today. I've written lots of copious notes to take back to the UK. I hope that we can continue to talk, continue to learn from each other, because I think that, to me, is where we will go into the future to improve the care for our patients and for our staff. Thank you very, very much.
Well, thank the professor, first of all, for causing my blood pressure to rise every time he took a step back, because there is a drop, and again, but thank you very much. And again, I think it's really interesting. I would love for us all to chat in 2 years' time. You have a new government, we'll have a new government. Let's see who's actually done the things that they said they would do. Thank you very much, Professor. Professor Ed will also be here for the panel discussion immediately afterwards as well. So after our coffee break, we're going to have a coffee break in a moment, guys. We'll take it till maybe 11:25, if that's okay. So you have 25 minutes. Just a couple of really quick things. First of all, anyone here who would prefer that their image is not used online digitally, you will see there's cameramen going around and taking pictures. And genuinely, if you would prefer not to have your image used in any of the recordings, if you can just let the team know before the end of the day, just we will edit you out, we'll put a bubble over your head or something like that. But we will make sure. And it's fair. Some people that that will not be appropriate or don't want that, and that's absolutely fine. So just let us know. We're going to break for coffee. We would ask everyone to come back at 11:25. We have a panel discussion, some very interesting speakers. I would remind you, if you again look at our hashtag PFA24, let's get it trending. So if you have photographs, obviously get permission of the person you're taking the photograph of. And you want to put something up, absolutely want to hear that. But can I just thank all of our speakers? We had some brilliant clinicians, but I also want to thank in particular our patient advocate, that patient story. That was fantastic. Thank you so much, Catherine. Thank you. Right, guys, get caffeined up and fed and watered, and we'll see you in 25 minutes. Thank you.
You notice that the lights have changed. Crowd of people stood on the stairs. They'd seen his face before.